시청자 여러분 안녕하세요.
Hello, viewers. This is Friday Night Live on Prosthodontics on Friday, looking at various issues related to dental treatment. So, with the full denture as the big topic in the Back to the Basics series we've spent this year, and the year is about to be over. Today we're going to look at single denture, and our lecturer today is Professor Song Young-byung from Dankook University. Thank you for coming, and thank you for serving as a lecturer for this session. I think we had interior aesthetics covered at your last lecture, and today we are going to look at the single denture. And could you maybe give a summary of your lecture first? And today, the area that we are going to look into is single denture. Yes, it's a rather tricky area, very stressful area for me as well as others. But as back to the basics is our big topic, I'm going to focus on basics. So I look forward to your then lecture. Now, if you're joining us live, please use our chat box to leave comments and questions. If you leave questions, we will answer them, and we also have lucky draw where you can win Starbucks coffee coupons. Especially if you're chosen as the best question, then we'll give you 3 coffee coupons. So we look forward to your active participation. So we will start with today's lecture. The topic I'm going to cover today is single complete denture. And as introduced, I'm from Dankook University. My name is Song Young-byung, and this is my agenda. Now, single edentulous arch is something that you actually see often, especially on the lower side. Cuspid incisors have a longer lifespan, so we often more see the maxillar single edentulous arch. And maxilla compared to mandible, prognosis is then better for denture. So compared to lower side, the upper side, restoration with denture is something you see often. And due to limitation of bone quality, it's tricky to place implant, so dentures seems to be more favored option here. So if it's single denture, then biomechanics understanding is required, especially for patient that of course also for surgeons, but more so for patients. And for long-term successful prognosis, clinical observations and surgical techniques are required. If tonight you have this type of match, it will be very interesting and many would like to enjoy it. And this is Asia Cup match between Korea and Nepal, and I believe in our soccer history, we had the biggest scores over the opponent. It was 16-0. So more than 3 players scored more than 3 goals. So as a winning team, it will be good, but it's not an interesting game. And especially if you're on a losing team, it will be very painful. So the difference in force is also evident in single denture. In the natural teeth, you can chew up to 20 kilograms, but if it's full denture, maximum is 6 to 8 kilograms. So there is a difference in strength or force in terms of support. Natural teeth will be 45 square centimeters, but the full denture, it's half of that on the upper side, and on the mandibular side, on 1/3 of that. Hence, especially on the single edentulous arch, denture restoration is not easy and comes with a lot of different complications. If you look at some of the complications, if it's edentulous area, there could be severe bone resorption resulting in accelerated interridge discrepancy, especially because we have more maxillar denture. Class 3 would be more frequent, and it's better to have bilateral balanced occlusion. But on the mandible side and the opposing, if you have teeth, it's very hard to make adjustments, so it's really challenging. And artificial teeth is mostly resin, so even if it's restored teeth or others, if there's a wear, there could be difficulties. And because it's like sometimes stability, bone resorption could be more severe, resulting in fractures. And if there is a teeth remaining, means it's not such an elderly patient, so whether they can accept wearing denture. And if you are wearing denture for the first time, whether they can adapt to that new situation could also be challenging. This relates to patient demographics being rather young. So on the lower side, support might be less, but you can use implant, other prosthodontics, so you lean more toward the implant placement, something like this, over dentures. However, on the maxillar side, it's a different story, especially on the maxillar, it's edentulous, and if there's no posterior on the mandible side, then it becomes more serious situation, and you call that combination syndrome. And for combination syndrome patient, on the anterior maxilla, there's a lot of bone growth, and there could be overgrowth of the tuberosities, and because of that, in the hard palate, you'd see papillar hyperplasia, and there could be extrusion of the lower anterior teeth. And another thing is that there could be loss of bone under the partial denture basis. So if there's different issues and a lot of bone resorption, for balance, you reduce occlusion on the anterior sides and try to secure through occlusion on the posterior side. So for this patient, it was really severe case. On the mandibular side, the patient had a cuspid, but on the maxillar side, used too much, so there's a lot of bone resorption. If you lose this person's model, there's this much of difference. So the combination, it's a typical case, in other words, of combination syndrome. So when you create denture for this patient, it comes out like this. So if you see the cross-section through skin, then on the frontal side, where there should be a alveolar ridge, there's no support, so ridge has been resorbed a lot. So if such a serious situation on the anterior bite side, then if it's edentulous area, you have to be very careful. And also, if there's a denture, then movable, it could be moving. So on the occlusion area, bilateral balance occlusion is something that you need to achieve. Hence, if you see the definition of bilateral balanced occlusion, not on the anterior but on the posterior side, occlusal contact is being emphasized. And as you know, if you move a working side, even the balancing side, artificial need to come into contact. However, like this, there is excursion. Then on the working side, it's a contact, but on the other side, if there is such a space, then if it's edentulous on upper and lower, then there could be some offset. But if it's single edentulous situation, then it only happens on one side, resulting in more severe movement. So he has used denture for a long time, and if bilateral balance occlusion without food, you proceed. But as you see in this patient, after having food, he doesn't use both sides molars, but only one side. Only on the working side is the one that he uses for chewing. Then only one side comes into contact, then bilateral balanced occlusion. Why do you still insist on that? It's because, as you can see in this slide, for CANLI guidance or for the group function, posterior, if that is the base, posterior, not a working side, but on the balance side, there's elevation. So here, when you chew food, then not working side, but on the balance side, on the maxillomandibular side, the difference is rather big. So bilateral balance occlusion, if that is achieved, that gap is reduced. Hence, you can secure more stability. So if it's a single edentulous situation, you have to aim for the bilateral balance occlusion for the stability sake. Now, edentulous patient, before doing denture restoration, you need to plan ahead and make some adjustment ahead. The opposing side has teeth, so you need to analyze situation and see how you can gain stability by moving what. So you need to plan ahead. So there is imbalance, so there could be the teeth arrangement, occlusion, there could be not in sync in terms of occlusal plane. So what to do to achieve balance? So for me, if it's single denture, the opposing side, I always try to analyze using the diagnostic model. So I try to project where there could be interference and issues. So they recommend using occlusal template in such a case. And in analysis, the problem that you often come across is that if on the mandible side, due to the angle on the front side, there is a protrusion of the distal cusp, and that is hard for stability. So it's very important to have 2 or 3 millimeters of the FRIDAYM on the back and front side. So less teeth arrangement, or if you can adjust the mandible teeth, that would be good. And adjusting on the opposing side, you can use the orthodontics or restoration, but there is a realistic issues. So naturally, sometimes we try to move or adjust. But if it's really severe case, then without, I just explain the patient before and then just push for the restoration. So sometimes I try to talk to the patient and try to adjust situation, but that could lead to more problems. So if there's a lot of things to be adjusted, I think it's better for the patient to go straight to the restoration. So I said occlusal template can be used, and this is using monsoon sphere of 4 inches, but in the older literature, there's a metal template, but it's hard to use now or get now. They sometimes say 8 inches the volleyball, so they say they use it for the template making. But now we are living in the digital age, so there are Maximus or other free programs, so it's easy to create with that 4-inch template. So I designed this type of template, and with printing you can create this type of things. And in analysis, if you use such a template, then it can be very helpful. And also, this is using the 3D system, and you can make adjustment on the CAD and adjust where there is an overlap, print it out, and in the mouth, you could also make corrections. So on the left, it's delivered to the mouth, and on the right side, on the posterior, on the number 7 distal, you see there's been cut. So of course, it doesn't solve all the problems, but by making such adjustment, single denture can become more stable. And also, occlusal for centralization, reducing the occlusal plane will be necessary. So on the mandible side, lingual side, we elevated, so you cut that often. But rather than that, buccal and lingual side, you cut more, so that overall occlusal table can be reduced rather than the overall side resulting in reduction. And before treatment starts, what is most important is educating the patient. Biomechanically, the patient do not know that they are in a very unfavorable situation, and it's a tricky treatment. And you have to tell the patient how difficult it might be, but we need to have a good partnership and work together. And you need to tell this beforehand. If you tell it afterward, it could be only a doctor's excuse. Well, if I may ask questions before we proceed. Now, in single dentures, opposing teeth remain, and there's a wear in the occlusal plane, and the plane becomes very flat for some patient, or cusp is still there. So sometimes there's irregular, teeth surface. So if you create single denture, patients, in what cases is it better for mastication? Well, generally, on opposing of the mandible side, if the occlusal plane is flat, then you could say it's stable. So when you create single denture, yes, everything becomes more adjustable. But that's my experience. But cusp, if you had some, the prognosis was actually much better because chewing pattern is different by patient. And generally, if you have good biting for, there's a lot more wear. But if the cusp is still there, the mastication is more happens vertically. So if there's a wear sidewise, there's a lot of load put in. Yes, I understand. Well, thank you for that answer. And if I may see our live chat box, there's a lot of comments that's been already posted. So it says, thank you for a great lecture. I see that. I'm joining live, and very interesting topic today. And ID Sangdi says, I look forward to every Friday for this lecture series. And ID Wang Dukkan says, I always look forward to Friday lecture series. And the Dental Life ID says, I am enjoying this lecture and says, have a good lecture. And Yorongi ID says, I really like you professors. So there's a lot of supporting and comments. And HP 9599 said, says good place for denture. That's interesting ID. And I'm honored to listen to your lecture, Professor Song. And Smile says, full dental lectures is already coming to end. I wish it could go longer. Well, so overall, there's a lot of comments, and we will choose one to send a coffee coupon, HP 9599. So I'm honored to listen to Professor Song's lecture. So I'll just, in my discretion, send this person one coffee coupon. So thank you for your all nice comments. And please stay active and post a lot of questions. And again, the question that you pose on our chat box after all the lecture is complete, we'll try to answer that. So please continue with your lecture. Well, actually, when you create single denture, what you need to look out for is that this one slide in this chapter, I believe, is the most important slide. So generally, without doing implant, if you create a conventional complete denture, then using metal-based denture or mesh needs to be used. And in terms of occlusion, lingualized occlusion or crossbite occlusion should be considered. And artificial teeth and natural teeth could also have wear, so you need to consider responding to wear. And another thing is that, of course, on the mandible side, if you could place implant using overdenture would be recommended. And in case of soft-based denture, in the past, Oculus B were used as a soft liner, etc. And I wanted to use that, but there was not many labs left using that. So currently, it's very hard to use this. So rather than that, dental implant, overdenture, a hybrid bridge would be wiser choice these days. Then the biggest problem, which is wear and fracture. So how to reduce such problems. So wear of artificial teeth is often when you use resin teeth, so metal occlusal plane, or you could use also porcelain artificial teeth. Porcelains were not really available in the past, but nowadays you can cut with CAD/CAM and use zirconia, so it's readily available. But if you use such artificial teeth, if the opposing teeth is not natural teeth and not restorative one, then you need to think carefully. And if you use this type of artificial teeth, there could be some sound where the teeth comes into contact and patient might complain about it. So you have to see whether the case is good for using this type of artificial teeth, and you have to check more often. So reduce the patients in coming to the clinic intervals, so that he can come to the clinic more often. Another issue might be fracture. There is a difference in the occlusal force, and some areas have more severe bone loss. So if it could end up denture not being fit. So if you line them, etc., the metal base or mesh can be, should be used. And I think what I pay more attention is that post fracture sometimes or often start with crack in the central incisor. So frame can be extended in that area so that everything can be more in place. And if there is extension on the front, it might be better, but it could also mean that if inlining, you have to do it longer for this type of patient. So on the right side, full covered metal, if it's used, then the lining can be more tricky. Even if you do that, result might be not satisfactory. So in the posterior area, resin based metal base should be used, or mesh should be used, so that when you do relining in the future, the materials can be more in place. So this is when metal base was used. And when I see patients, delining with the direct approach is not what I recommend or enjoy. So even if it's done at the lab, the metal area, if it primer is coated, the mouth, there's a difference in temperature. So in the end, there could be problems and resulting in smells of the food getting stuck, and there could be also fracture. So rather than this, like this case, on the posterior area, if you use resin, even if there's metal in between, it doesn't really come loose. So from the beginning, please consider as your design. And when you arrange teeth, as I said, if it's edentulous on the maxilla side, especially distal on the second molar, there could be elevation. So if it can be adjusted, it will be good. But if that's tricky, then to number 6, doing the denture arrangement might be considered, or artificial teeth, use it in smaller side so there will be no interference from the posterior side. And also, if you're not for those that are using it for the first time, but especially on the maxillar denture, there could be resorption if you have used for a time. So the occlusal force goes toward the outside. So it's as if when you go camping, try to break wood like this, what happens. So occlusion for going to the ridge is very important. So do crossbite, so then the mandible side, you move more outside, so that occlusal force on the ridge side, it can be moved more in that direction. If not, then lingualized occlusion can be used, so that where the chewing area would not be on the buccal side but more on the palatal side, then it's better to put force on the ridge. So doing teeth arrangement like this would be better. And FGP technique could also be used, and in such a case, then a lot of different steps are involved, so it's rather complicated. But basically, FGP uses articulator and move articulator that's mounted and try to cut. It's not cutting by mounting the articulator, and it's more using the functional occlusal path. So this is from Gyeonggi University literature, and as you can see, on the left bottom, using FGP wax, move the mandibular side, and then create to make it more hard. And what comes into contact, remove it and wax up. And the denture is full zirconia denture. And this could be a way, but this is very specialized case and takes a lot of efforts. But I just wanted to introduce you to that such a approach can exist. Lastly, after treatment, after delivering the denture, what you need to do. As you know, in such a case, it's there's a really big difference, from wearing it, using it. It can also become problem later on. So I think two things you need to consider. As I said in the beginning, the most important thing is understanding of the patient. So before starting the treatment, you have to make the patient aware that this is a tricky case and can be very hard. But if you adjust yourself well, and you can have a good result. And in recalls, again, you have to be more regular, more see them often, and be more focused in seeing them in recall. And of course, it will not get rid of all the problems, but at least reduce the problems. After the wearing, you could suffer from wear or fracture, and ultimately wear itself, fatigue wear is what you see most often. So in the maxillar denture, palatal, there could be a lot of wear, and also artificial teeth or denture fracture are something you should also consider. So relining is something you should always be mindful, think about it, and using such a soft liner, stabilize it, and then with switch to resin. So that indirect approach is what I recommend. And, for the long-term, liner, I thought it was good in the past, but these days, not many doctors actually use them. So for this patient, as I said before, relining on the condition that will happen many times, you start the design. So for this patient, had a gold-based denture, maybe he was rich, but he found it very uncomfortable to wear it. So I wanted to relining it, but it was not good option, but teeth had problems. So we say move left and right. But when you chew, patient on the buccal side and comes toward more inside. So buccal is the first thing you come into contact. So if you contact on the buccal that has no wear, it's not really stable. So for this patient, cut on the buccal side so that the initial force, other things can be reduced. I think that would be better approach. So reducing and a kind of fine-tuned adjustment is necessary. Otherwise, it's not on the crack can happen not on the front side, but where there's a lot of wear.
상악 전치부에 있는 데에서 크랙이 시작되는 게 아니라 그렇게 많이 달아 있는 부분에서 크랙이 시작될 수 있습니다. 이 환자 같은 경우
So number 10 and 16, there was crack for this patient. So it looked buccal. There was a lot of contact, but there was no adjustment. But on the inside, there was a lot of wear, resulting in such a severe problems. Another thing is that for this patient, what I felt is it's elderly patient over 65, and Denture was covered insurance and had 3 lining where he wore this for 5 years. But it needs to be happening again because on the mandible, there's a strong force, and there was but one issue. So relining, it's reimbursable, but only reimbursed once a year. So if it needs to happen twice a year, it's not covered by health insurance. So patient needs to be aware of that beforehand. So you need to tell the patient beforehand, and patient needs to cover the cost, him or herself, and that could reduce the resistance of the patient. So tell the patient before. And so that's it in terms of my lecture. Well, thank you for a very nice lecture.
예, 송 교수님, 좋은 강의, 멋있는 강의 감사드립니다. 예.
Then we will look at some questions that's been posted in our chat box. Now we have from ID Bora, class 3 case. How do you do arrangement? Now for class 3 case, posterior side, in terms of arrangement, not much of a difference. So typically, if it's class 3, you do crossbite arrangement, but anterior might be issue. And as I showed you in my first case, if it's severe resorption case, then to block biting on the anterior side, having a bit of overjab would be recommended. If it's really tricky case, then the anterior doing crossbite I hear sometimes used, but I don't really recommend it. So I think anterior crossbite might not be aesthetically pleasing. But the thing is, if you overjet a lot, because of the lips, the maxillar denture could actually come loose. So in such case, inevitably, then you have to opt for crossbite on the anterior side. Well, when you make it, then the overjet on the teeth side, yes, there might be, but on the vestibule side, then whatever the denture, I think it needs to be more concave. So that area muscles can, fix the denture in place. So they can be used, the planes can be adjusted. So possible, edge to edge overjet, but not crossbite. Yes, that's what you're saying. And next will be S191908, says for the single edentulous or single denture, how do you adjust the occlusal plane that's been distorted by the opposite denture? I don't know where do you do adjustment, but anyway, basically what is most important is parietal balanced occlusion, whether you can obtain that. So I think it seems to say for the remaining natural teeth, for bilateral balanced occlusion, it might be tricky case in terms of occlusal plane. So then how do you make changes or adjustment? As I said in my lecture, I am very aggressive in doing the adjustment in the opposing teeth. So just to reduce cost for patient, sometimes the results are not favorable, and you could have more problems on hand, so be more aggressive. So try to use prosthesis, otherwise using the various systems to create guides and other things. Yes, for adjustment. And another question, rather than doing the teeth adjustment, if you use teeth restoration, wouldn't they resist because of the cost increase? Well, as I said before, yes, there is a resistance on the cost side, especially because I'm with the university dental hospital. So in the beginning, I did only adjustment, but with recalling of the patient, it was really stressful for me, and sometimes that broke rapport with the patient. So to the patient, please explain ahead. Of course, if without gold, using gold, with only metal restoration, adjusting the plane is actually much better for later on also. So it's very hard in the beginning, but persuade the patient so that you can have more or better long-term prognosis, better for the patient and also better for doctor. So it's a win-win strategy. So persuade the patient, even if they start with higher cost, it's important to persuade the patient. Yes, I think at the small clinic, it's hard to persuade the patient much more so than in your case in the university hospital.
혼자 설득하기가 더 쉽지는 않을 것 같습니다. 그죠? 예.
But anyway, another comment. Thank you for very nice lecture.
이거 설명해 주시니까 감사합니다. 교수님 최고라고 썼습니다. 그다음에
And then another question. After full mouth patient prosthetics restoration treatment, what do you do if there's TMD? Then there was full mouth and then you had TMD, or there was TMD already in progress, and after recovery it actually becomes severe maybe. So for full mouth patients, I believe today we are talking about denture, but here maybe full mouth that relates to implant. What do you think? That could be a possibility. And personally, after restoration, having TMD is because TMD if it's start in a very unstable situation, you could have that on your hand. So take CT or do TMD projection or take panorama picture. So see whether there's TMD. Sometimes you don't really see it. So look out for that. So before treatment, be careful and do full observations, and full mouth patient angles and other things can change. So doing provisional and temporary should be done before delivering the finals. So if there's a lot of stress, or it can be tricky, and if you try to increase too much at one go, it can be really stressful to TMD. So step by step would be better, and use provisionals as Professor Song said, and use denture or treatment denture with a vertical dimension, etc. might be better options. Professor Song, I hear you are also coming back on October 4th. It seems to know you very well. And another question, single denture patient, occlusal force was well, so there's a lot of crack on the palatal side, even with the metal base. So with the occlusal adjustment, can I make so that there is no crack, or you just have to accept cracks and maybe continue with frequent repairs? So not many cases, but sometimes you see such a patient. So it looked okay, but there is a frequent fracture. What do you do? Well, if that's the case, then for me, occlusal adjustment might be good, but I will look into the inside of the denture. If there's a crack, then mostly on the palatal side, there's a support. So maybe doing relief might be a good way to solve this. So in the central side, you push in. If it's too hard, then have a sufficient relief from the beginning. Yes. Okay. Then sometimes I also saw that type of patient, but sometimes metal breaks. And I've also seen that such case. And HB9599 said, sometimes I don't know what to do with the denture treatment, but I'm learning a lot during this lecture, so I think he's just expressing his thank you. And then another person said, when you create single denture, if there's irregularity in the mandible occlusion plane, then do you make adjustments using prosthesis, or do you just go ahead with given situation? No, I am very active in making adjustments, so I have a very active intervention. And then there's another question: if there is anterior teeth on the mandible side, try to chew on that side, so upper full denture drops too often, resulting in uncomfort. Is there a way to change the patient chewing habit? Then I use temporary until the habit stabilizes. So by habit, because there's a teeth still very much on the anterior side, so the resulting in such a chewing habit. So using kind of provision others try to move on the CR positions, make such adjustment, then it will be very helpful. So it's not easy, right? It involves patient education. So, make him come back after 1 week, educate him again, and through continuous training education, not protrude on the anterior side, but CR position or CO position, try to in that way. So you have to be really good in training and educating the patient. And another question: how do you train denture patient? I always think I'm falling short in this area. Could you explain that in detail? Well, for me, when I talk about dentures, I use the analogy of shoes. So when we wear shoes and doing marathons and climbing, always makes our feet very hurtful. So it's there's a protection, but it's not really your natural teeth. There's a difference, and especially if there's edentulous area, even if you have shoes, but if you try to hit with the hammer, then there will be pain. So you have to put hammer, while that up to area that's not painful. So you have to chew not too hard things, right? So for denture patient, expectation level is high, so it's very, very much better to start to lower the patient expectation. So if especially the tricky case will be like with the still teeth is remaining on one side. It's like trying to break egg on the stone. So another question is that you said for combination syndrome, you have to recall the patient very more often. So how do you do that? Not have the anterior bite not come into contact, and push on both sides, determine, and then relining. So what is your checkpoint steps? Well, typically, if there's a possibility of combination syndrome, then I try to recall in less than 6 months. And on the anterior side, whether it bites is first thing I check when the patient comes. And molars biting with the check bites, well, denture moves together, so it's not really get you exact results. So in that area, push gauze or wax and let the patient bite, and if the result can be checked to see whether the lining is necessary or not. So the most important thing is whether it's timing for relining, or can I observe or monitor for a longer period. So in other words, whether there's a posterior support. So posterior check support will be your checkpoint to see whether there's really align timing or not. And then another question is that you are like a sunshine to patient, to other doctors because your lectures are so good. And then we have ID PROSTHOC. So metal base and resin base, how do you make choice? Generally for metal base compared to resin base, there's a stronger initial fracture. So in that case, metal base would be my preferred option. And then another question on the anterior border area, if there is a crack versus there's a crack on the palatal side, or if there is a crack on the outside border of the posterior side, would the response be different? That's a really tricky question. Especially, well, first, on the outside border, posterior side, if there's a crack, then rather than a stability issue, it's initiated by occlusion. So occlusion adjustment is what you need to see. But on the palatal or in the anterior border side, if there's a crack, then palatal comes into contact first, and the ridge crest on both sides comes to contact later. So because of bending moment, there's a fracture. So in that case, relining would be an option. So you have to do relining, and also thickness on that area. You have to make it thicker. Would be also a way to go. And next will be KTW0103. In case single denture, there is concern of combination syndrome. So how do you follow up? How often do you recall that type of patient? As I said, for me, in case of single denture, within 6 months, less than 6 months, will be interval. It depends on the patient, but every 2 months in the beginning, sometimes I even do that. And then PROSTHOC for metal-based, what would be, when do you use mesh type and when do you use plate type? Well, yes, there are meshed and plate type. And a plate type, you can create very thin things, so it's good. But mesh type, it's a bit thicker, so in lining it's more helpful, but for patients it might be more tricky to adjust. So plate type, in the back side there should be resin resin added. That possibility should be considered, right? Yes. Now if you single denture, then anterior comes in contact and doing adjustment, anterior becomes shorter, maybe because of the wear on the posterior side. So how should I respond to this? So there's a cause, wear of the posterior. Then if there's wear, the artificial teeth, recreating them might be not easy. So if you make it again, then maybe metal can be used to respond to wear. But if you have to continue to use that denture, then on the anterior side, using resin, you elevate it, and the metal compensator on the back side could be another approach. So metal bridge or metal crown, if you use them, then posterior wear can be slowed down. Anterior situation also would be better, right? Yes. Okay, and then another question is, he seems to be a fan of you, has a good thing to say about your lecture. And another question, thank you for analogy of shoes. And another question, in case of single edentulous denture, then sometimes you have touch and slide of the upper denture. If you have fixed denture on the lower side, so use clinical remounting for adjustment, or any other tips for the occlusal adjustment chair side. Well, for such case, there is a limitation doing adjustment on the mouth. So for that case, I use clinical remounting. Yes, clinical remounting, you think would be better option. Yes, it's because clinical remounting is it's easier to see the first contact point. But if you do in the mouth, it's very hard to find that, and sometimes you go where you need to not go. So I think clinical remounting would be the best option. Yes, it might be best option, but it takes a lot of time and efforts. Yes, that's true. You know, there's different steps. You have to make adjustments in between. Patient cannot use the denture. Well, so for me, one tip would be basically plastered block mount is what I have. So denture fixed bite with aloe wax, and I fix it with glue gun first and do adjustment at that time, and glue gun comes up very easily, and that doesn't really take a lot of time. Yes, thank you for that good tip.
좋은 팁 감사합니다.
Says learning a lot today. Now another question. Denture teeth, why some patients have a lot of more wear than others? I think that means the bite area, there's a lot of fatigue wear. So there could be different reasons. But for this type of patient, grinding is what they do more than other people in chewing. So yes, that might be the case. Another question, Evoclaw system, how is it different than generic plastic materials? So what's your answer? Well, Evocam, I think that's the system the person is referring to. So the strength or the force it's really strong, so it's hard, but it can become brittle. So compared to what's heat treated, if there is a broken, it breaks or fractures, it might be a problem. But I think accuracy-wise, Evoclaw system is better. I also agree compared to other systems. There's a heat that's been put on, hence the error-wise is reduced, and I feel that that's because of that it's more accurate. And then another question, well, using your tip, if you do clinical remounting, how much time does it take? Well, when I do clinical remounting, then I'm at the university hospital, so take bites, and resident others do remounting, and can be less than 1 hour, so patient can wait and take it back. Mostly, yes, they wait and take with them. And relining with indirect approach, so if your lab is close by, then you can say, give denture in the morning and patient getting it back in the afternoon, so not more than a day. Yes. So anyways, there were a lot of questions, but I believe we were able to answer all of them. So thank you very much for very nice and good answers. And thank you very much for those that have asked questions. Now we will select best question. And that selection will be done now, and 3 Starbucks coupons will be won. So Professor Song, please select one that you think is the best question. I think there was ID, I can do it. I will select that person. Yes, I believe that person asked very nice and good questions. Congratulations for being selected as best question. And we will send you 3 Starbucks coffee coupons on Monday. Even if you do not been selected as best question, don't be disappointed, because we will, through lucky draw, select 7 people to win coffee coupons.
중에서 추첨을 통해서 7분께 커피 쿠폰을 보내드리도록 하겠습니다. 자, 송 교수님 이제
Anyways, I think we have neared the end of today's lecture. So, well, thank you for being with us for today and giving nice lecture. So before you go, maybe some last comment. Well, I also learned a lot from other dentists and colleagues. We talked about single denture, which is not easy, and theories, and I hope that you learn a lot through theories and through experiences, and through that I hope you become better a doctor for you and for your patients. Well, thank you for coming all the way from Cheonan
감사드립니다.
for delivering nice lecture. Well, this concludes a lecture on single denture with Professor Song Yeon-gyun. I hope you enjoyed today's lecture, and if there are any question we did not answer, we will post our answers on our chat box, and digital denture will be the next lecture topic. Well, thank you for being with us until the end. Thank you very much.